We come to the second one, now focusing more on weaning. So in patients, infants recovering from severe acute respiratory syndrome, from Marco Piastra from Rome, Italy. Marco, please.
I'm really happy to be here talking with this new technique we applied to our sicker patients, but in an uncontrolled or unrandomized way, because we were really interested after the first experiences about Nava due to its high potential, for impressive potential in synchronization. And then after the initial experiences, we think to apply this method to our sicker patients in the weaning, in the recovery phase of a severe ARDS. This is why we made this uncontrolled, match-controlled study in the last years, planning for a future randomized study in acute lung injury patients. This was our aim, and then we started to be interested with Nava and facing the differences, the difficulties in finding data about lung injured patients, because this technique, which is a new, unconventional technique to control the ventilation, not only the synchronization of the ventilation, but the pressure assist, the pressure assist itself has been provided from a few years in our units. A quick look to its potential. It can control the timing and the intensity of the pressure support itself, strictly depending of the EMG of the diaphragm, expressed as the EDI signal, which the physician can amplify with to obtain some more support, but it remains incredibly synchronous, and the ventilation itself is proportional. But not only this, the neuroventilatory coupling is preserved, and it appears a variable pattern that is completely different from the homogeneous pattern of pressure support that you can apply to your patient. In the first case, you have a lot of pressure assist events that are synchronous if the ventilator can detect even the little flow variation made by the patient. In the second case, you have a completely variable pattern, and this is of really interest also in the last studies. Rapidly, a quick look to the experiences, the work made by the Finnish group some years ago, comparing pressure-triggered, flow-triggered, and Nava phases of ventilation, and the evidence that Nava was incredibly more synchronous than the previous technology, and the demonstration of that we can achieve a lower peak pressure by maintaining plus or minus the same ventilation during Nava. This is one of the works by Jennifer Beck and Christer Sinderby that they developed the Nava technology, and they studied a lot also premise by demonstrating, interestingly, that Nava invasive and Nava non-invasive, they were not so different. This is another main characteristic of Nava, the possibility to make the same kind of ventilation, both invasively and non-invasively, or with the enormous leak, as in nasal one-prong interface of nasal masks in neonates. Then a great property of this technique, in the last months, in a non-invasive European meeting made by my friends of Hispanic group, Dr. Stein demonstrated also that Nava non-invasive was able to shorten the ventilatory time, the time on ventilator of premise. This is, I think, a major point of discussion for these patients. But for clinical experiences, in the last years, in 2010, 2 works independently conducted by an Irish group and a Scandinavian group, I think, from Göteborg. They studied mostly post-operative cardiac patients with short studies with a crossover design, demonstrating that Nava could achieve a lower peak inspiratory pressure with a slight increase in respiratory rate for these patients, but that Nava was at the end really well tolerated, was really safe, and the patients were really, really synchronous with the ventilator. To end up with this elegant study from the group of Professor Rimensberger in PCCM last year, in which all the possible asynchronies occurring in PSV in the preschool population of infants were studied, and the demonstration that Nava was able to dramatically reduce all these different asynchronies. This is not a matter of only of elegance. The asynchronies are always linked to increased sedation, prolongation of ventilation, and increased work of breathing, and maybe possibly also with lung injury. Then there is a great interest not only in obtaining major synchronism, but also in reducing, possibly reducing, the time on ventilator and the lung injury. Our experience was conducted on previously oxylated infants. The choice of previously oxylated infants was linked to the fact that they were the sicker patients we had, and that their diaphragm was switched off by apneic sedation, deep sedation, or paralysis. And then we choose to apply before PSV, standard technique, before 2010, and then Nava in the weaning phase when the patient was able to be weaned. The criteria for HF for oscillation shift criteria in our unit are protocolized with plateau pressure exceeding 28 centimeters of water, or VO2, the impossibility to obtain VO2 under 0.6 with the saturation, peripheral saturation over 19. But the winning criteria were the distension pressure, continuous distension pressure during HFOV of less than 15, or VO2 less than 0.4 with with the saturation 19, but without important drops on suctioning. This is the first patient. Her name was Michelle. Looking at the two groups, we chose the 2 patients for each patient treated by Nava in the historical group, but historical not so the time window is really narrow, and then we had the same protocols for these patients. And the only difference between the 2 groups was the duration of HFOV that we couldn't adjust. We accepted an HFOV duration longer in Nava patients. Looking at the diagnosis, we had several past premature babies in these groups, with only one patient with a definite diagnosis of BPD in the older group, and 2 patients in the more recent group. Severely hypoxemic at the onset of HFOV, obviously, and with the age range about 8.5 to 7 months, the same for the weight. Again, another picture of one of the chest images of Michel, the initial patient. After 8 hours from the introduction of both PSV or of Nava in more recent patients, we noticed an increase in the hemodynamic impact of the PSV in respect of Nava. In fact, patients given PSV demonstrated with the same sedation protocol given, which in our unit was remifentanil 0.1, 0.15 micrograms per kilogram per minute, plus midazolam 1 to 2 micrograms per kilograms per minute. A greater impact of the PSV in terms of increase in cardiac rate and mean arterial pressure, and a greater loss of oxygenation as expected by in the transition from the oscillatory ventilation and the trigger ventilation itself. But the ventilatory variables were not so involved, but except for peak pressures that were lower in Nava by keeping the target tidal volume between 5.5 and 6 milliliters per kilogram. The rate also was increased in Nava. It's interesting that the invasive mechanical ventilation duration was really lower in Nava given in Nava group in comparison with the PSV group. The numbers are so small that we actually only take these results for planning future randomized trials, because it's really difficult to say anything. But at the same time, with the same level of sedation, the comfort score that our nurses are having their sheets was paralleling this fact was lower, indicating a lower level of agitation in these patients. I think that Nava will give the clip is not working, but it's not important. Will give us the possibility, our opinion at the end of this preliminary experience is that Nava will be giving us the possibility to shift really early the mostly lung-injured patients from invasive ventilation to non-invasive ventilation using this technique. This was the opinion at the end also of the respiratory mechanism controls. This has been showed really well by the other groups, that we have a lot of asynchronies in the normal, also well-regulated PSV that are really disappearing with Nava. And this is the secret leading, if you have an open airway and and a good capacity of clearing secretions to shift early in Nava. We have used a lot of interfaces. We also have used the rotation of interfaces to study for these patients. Normally, the patient was in nasotracheal intubation with Nava, and the first act was to put the tube in the supraglottic position. But then we used also total face mask, we used also nasal mask, and at the end, the helmet. The patient were the worst patient infants we had in this time, and then it's really interesting to plan future studies. But we really didn't see any difference between the activity of the intubated patient with its variability and the same. This is the last patient, and the same in non-intubated patient. I think that this could represent a real advantage for these patients. I know that some groups are working also on Nava with the helmet. I know that Marty Pons is making. My friends of Milan is making. But I don't know if finally this will be the solution for the Nava. It's really, really tolerable by the patient. Recently, the head of my unit, Giorgio Conti, and the group of Novara made this investigation in adult patients, demonstrating that also with helmet, the Nava was able to really diminish, to really decrease the numbers of asynchronies and to be really tolerated by the patient. Now, what we know about Nava. Nava gave to us the magic of synchronism. Nava was demonstrated as effective as the previous PSV in terms of efficacy, was safe, was well tolerated. What we have to know is if this method could lead to a decrease of the time on invasive ventilation. This is really important, mostly in premise, but also in acute lung injury patients that suffer from intubation-related complications, tracheitis, ventilation pneumonia, superimposed sepsis, and the possibility to develop a new phase of the ventilation only with Nava-NIV. This is our interest, and this is, I think, the direction in we are working now. Thank you.
Thank you for sharing your clinical experience now with Nava in the face of weaning off after severe ARDS patients that have been on HFO. Any questions, remarks?
Thank you for this interesting study. I would like to get your comment on the interest of Nava for safer ventilation, because we have to keep in mind that Nava is an assist mode, an assist control mode, so the patient keep a certain respiratory activity. So it's very difficult to be certain, even if the inspiratory pressure is lower with Nava, which is very frequent. It's difficult if you do not measure the esophageal pressure to be certain that the transpulmonary pressure is really decreased. So more and more I feel this is very interesting. Nava is really interesting because it keeps the patient breathing, but on the other side, you don't know exactly what is the resulting transpulmonary pressure that is applied to the patient if you do not measure it. So if you can comment on that.
Comment. We have to make some comments. One comment is, when a patient has a long period on invasive ventilation, in our patients with oxylation, I say the respiratory muscles were switched off. These kind of patients have one major problem, that is the withdrawal syndrome. The withdrawal syndrome is a problem when you are judging the level of sedation, because you need to give them, in our practice, a determinate quantity of methadone to have a baseline. This is a problem for future studies. Now we are investigating, I said before, the use of dexmedetomidine for all patients receiving NIV, and this will be, I think, a major advance for this kind of patients, because the assessment of the level of sedation strictly depends, and also from the previous history of the previous sedation and or paralysis of the patient. A common observation also from the nurses, that we have some blinding system, because we don't care about sedation. Only the nurses are controlling sedation with their scales. Then we are switching a patient in Nava. Immediately the sedation should be decreased, because he's frequently oversedated, because the patients finish to fight the ventilator. Also with the PSV given in a perfect way. I think that this will be more deeply investigated in a controlled study, because all the opinions coming from retrospective, as in our case, from retrospective experience, may have some biases, selection biases. This is my opinion.
Marty Pons.
Thanks. So both lectures have been very interesting. So I think that I learned that really we are using, as I am doing in my unit, to shorten the weaning process. So, and it has been shown that for postoperative simple patients, so perhaps it makes no sense. So, but on the contrary, on severe patients, perhaps it's a great tool to reduce the time on mechanical ventilation. So about using NIV Nava, so which are you using it in this weaning process? And which should be the criteria, which are the criteria where are you using to extubate your patients from Nava to NIV Nava?
I think that we are still constructing this criteria, because the first criteria was extubate as soon as possible. I think the common criteria, but the airway patency, the ability to make coughing on stimulation, and is one of our extubation criteria. In my opinion, sometimes it happens nothing when the patient is extubed. If you have not post-extubation subglottic problems, the patient is the same. If you take a T-tube in the subglottic position or in the epiglottic position, supraglottic position, it happens nothing. This is the history of several patients, and it should be studied, I think, because if a patient has 30, 35, 40 days of ventilation, it's surprisingly easy to remove the tube, but leaving the assistance unchanged, because the pressure and the pressure synchronization, the type of ventilation is unchanged. The only change is the position of the tube. I think that we will develop new criteria only for these kind of patients, because if I have no change by removing the tube, maybe I'm late. This is my opinion, but Nava has taught us to remove the tube early, and then in the more recent series, patients are extubated when they are more hypoxic than previously. But this is an ongoing process. I have no data about this. And there is a big difference, a major difference in the new sedation drugs that are changing our attitudes, because the patient under Dex, for example, is sleeping with no problem. You can awake him, but afterwards he is sleeping without any airway obstruction. This is a major difference in comparison with Remi or any other opioid drug and midazolam or other.
We have some time left. May I ask the two speakers to give us an idea what would be your next study would like to do if you have money and time? Marco, you can go first.
The next study, I think, should be multi-center study, because of the number of patients for each center of these patients, excluding premature babies, excluding the neonatal period is too small to plan a study like this. My plan are for an early extubation study in acute lung injury, but I think that I will not be able to replace at all the ventilation for ARDS with Nava. In other words, in the acute phase, I think I will need to suppress the patient to recruit the lung at the best, but maybe we will be more early in achieving Nava vent, Nava NIV in this patient. I think that will give us the possibility to have one significant data, that is the decrease of the time on invasive ventilation. For the PICC stay, is much more different, depends on the variability of this patient. I don't know that we will have easily a decrease in PICC stay, but a decrease on invasive ventilation is a really good objective.
And which specific patient population you would study?
For us, ARDS patients, according to the new definition, moderate to severe.
Maria?
Not post-operative. For planning a study.
I think that I'd be very interested in studying the effects of Nava to the hemodynamics, and does it have effect on the stability of the patients? And then also, this morning we heard these nice lectures on the position of patients. How does it affect the ventilation? So maybe I think that Nava could be one and EDR signal could be one tool to assess the work of breathing in different positions in different patients. So plenty of ideas, I think. Maybe too much.
May I ask Marty Pons in the room? Would you do a study, non-invasive ventilation, Nava versus non-synchronized or different approach of synchronized non-invasive ventilation in acute respiratory failure?
Could you repeat?
Would you think it should make sense to do a study non-invasive ventilation, acute respiratory failure, Nava, NIF versus another mode of non-invasive ventilation?
Absolutely. We tried to do it in Spain, but unfortunately the other companies didn't want to compare with Nava at that moment. We are willing to do that, but at this moment wasn't possible. So really, I think that the most interesting point is the most asynchronic patients that are younger infants, younger than 6 months, and especially neonates. And we are really very interested to run such an interesting study.
For a study like this, you need to place the Nava catheter both in the Nava group and in the Nava and in the conventional non-invasive group, because otherwise it's really difficult to detect the asynchronous. We need a lot of Nava catheters.
It's a feeding sound, so it's no problem.
A lot of restrictions is the real, in our real world, we have a lot of restrictions, and then we have difficulties in giving a Nava catheter for a non-sick patient, for a moderately sick patient outside the study protocols.
No, I think even you do not have a EDI catheter for the NAV-specific ventilators. The major outcome is measuring the number of patients you are avoiding intubation or reintubation. So it's and it's easy to detect because you have high numbers in this small population, because they are the most who are failing. So really, we don't need at all to measure. It would be great. So for physiological studies to compare the asynchrony index, but I think that in order for clinicians to know our measure objective is to avoid intubation or to shorten the weaning process. So I think it can be easily measured without
major outcomes.
Yes, major outcomes.
Okay, thanks. I think we have seen that we are slowly stepping forward with the Nava in the pediatric field. So after we had these asynchronous studies, now we have some first clinical experience that's showing us some indicators might be there that we have really to search for and to have then the possibility to do the right studies. So for those who are interested in Nava and may want to have more information, you can consult a website which is www.criticalcarenews.com, and in this website you'll find Nava presentations almost from the beginning, so explaining how Nava works, and many of the different conference talks that have been given are recorded there. So if you have a chance, have a look at it. Thank you for an interesting session.